Hi, I'm Diego. We are with a presentation by Carl Leitner from World Health Organization, or WHO, which is not the musical band, it's the other one, the other WHO. He will talk about the Hajj Health Card based on the IPS and the Global Digital Health Certification Network, GDHCN. Thank you, Carl.
Thank you. And there will not be any guitars being broken on stage today, so it's just WHO, not WHO. Okay, so thanks for the opportunity today. I want to talk about the Hajj Health Card, but I want to use it as an excuse to talk about some other work. But before I get into that, I just want to sort of put the Hajj Health Card into the larger architectural context, because what we're going to talk about with Hajj and what was done for Hajj is intended to be a repeatable pattern of using FHIR, using IPS, and using just infrastructure that can be used in other contexts. So if you came to the discussion yesterday, we talked about digital public infrastructure, and WHO is setting up a reference architecture to describe how typical systems interact in the health system, health space, like following generally an 80 to 20% rule, just to give countries that are beginning their digital transformation a way to start and some strategies to go forward, but also help coalesce and have a common language for countries that are already more mature in the digital health transformation. So in this architecture, what we're going to be talking about today lights up a few key components. One within the sort of DPIs for H, or the Digital Public Infrastructure for Health. We have a shared health record or a national health portal, something that is sort of a national system that's bringing together the relevant clinical data to populate an IPS or other health document. On the bottom, we have a trust network. We'll just talk about what that means, but it's essentially a public key infrastructure that we can use to verify health documents, the authenticity of what's being transferred, and how it's being transferred is through a digital health wallet, so an individual holding their own health records, the IPS. And so this is tended to be a common reusable pattern. And while we'll talk about the Hajj Health Card in a fair amount of detail, what we do want to do is really say what are these common workflows around accessing and sharing health data, what consent things do we need to do, how do we put all this together. And so we don't know all the answers. We're working with countries, with different regional bodies to figure out what these are. We also invite you to join us in documenting and figuring out what are the best practices, how can we move forward. This is going to be an iterative process. So we do have a call for experts to join our reference architecture working group. There is a QR code, which I hope works. Please yell at me if it doesn't. You can go here and go through the sign-up form. We have initiated sort of a core architects group. We've been meeting for the last month, and now in the next month or so, we'll be starting sort of sub-working groups to focus on different parts of the architecture. One of those is going to be around trust wallets. We have an existing community of practice. We need some experts as well to join in. If you're interested, please join. There will be other areas as well, but just to focus on the conversation for today. So what is the Hajj Health Card? So simply put, it's the IPS that Hajj pilgrims are taking with them as they go to Hajj. And so what is Hajj? That is an annual event where millions of people, millions of Hajj pilgrims go to visit Mecca and visit all of the holy sites. So this is a massive undertaking, and there's a massive health impact for this, right? So they actually served between 2 to 2.5 million. I think this year is close to 2.5 million of foreigners, as well as another cohort that's internal Hajis. And they are going through, they have sort of a set agenda of going through over a 2-week period the different holy sites. There's temporary hospitals that get set up. And this is from last year's stats, but there was 1,000 hospital bed. I think this year it might be 2,000 or so. So I mean, these are massive infrastructural undertakings for a very short mass gathering events. And they have people from all over the world that are coming to participate. And so how do they provide healthcare for this? So last year, Saudi reached out to us. They said, like, what can we do? We want some, figure out how the Hajj pilgrims can bring their health records with them. So Malaysia, Indonesia, and Oman participated last year. They had 250,000 pilgrims that brought their IPS with them on Hajj, and which is, and they were verifiable. They were authentic. There was a lot of security built around this. What we saw was really interesting was not only was the intent was that the pilgrims bring their IPS. If they need care, they can show it to the registration at the EMR. They have medication, problem history, what the IPS is intended for, right? And so they were able to provide, they saw in the ERs, 90% utilization of the Hajj pilgrims that actually had the IPS with them. They saw, oh, it was really important that they had as much information they had, so we saw a 90% utilization rate, which was really great. What we also saw, particularly with Indonesia, is you see that there's 200,000 pilgrims coming from Indonesia. So it's not just Saudi Arabia health facilities that are providing care, they send health workers with them. Those health workers, we saw also I think 10,000 scans of the IPS from the Indonesian health workers that were traveling with the Hajj pilgrims. So you can see that, and they were able to provide some of this care. And so that's also reducing the burden on the Hajj, the Saudi system, because the triage health workers that were traveling with them were able to provide that care. And you have to remember that a lot of the pilgrims are older, right? They don't have smartphones. They don't know necessarily what medications are on. It's like, oh yes, I take the yellow pill, right? So this is really important that they have high quality information. And we have a lot of people that are, don't speak Arabic or English that are traveling, and so there isn't really a common language. And so what we saw for the IPS was actually the first most important thing was the human interoperability, that the clinicians were able to see a common health document no matter where the Hajj were coming from, but it was structured in the same way. Sort of the mental work that they needed to do to understand what's in that document and review it was really reduced because it's the same type of document over and over. There's some limited actually ingestion of the IPS. Last year, they were less concerned about the actual semantic interoperability. What they were concerned was more of a liability issue. So what they did is they saved the PDF of the IPS that was produced by the origin country, so that they know that they had a rendering that Saudi was not responsible for producing, right? So the visualization of the IPS and the PDF was very important to them from a liability perspective. In any case, for 2025, they've already expanded. So they had one EMR last year, and they have 3 EMRs this year, operating over 65 hospitals. And the Hajj is really the first use case for an expanded use of the IPS within Saudi Arabia. They want to expand it to tourism in general. So as you go to Saudi Arabia, for whatever reason, and there's some large events coming up, I guess the Expo and World Cup, right? So there's some very large events coming up that you might want to go to. You should be able to take your IPS with you and have healthcare. So a little bit about how it works. It starts with the pilgrims and the pilgrim's journey sort of in the top. So before they go on Hajj, they have to do a health check in their home country. Do you have your right vaccinations? Do you have, what are your medical history, just to make sure that they're healthy to go on Hajj? So in that first step, during that health check, they explained how to, or provided access to a QR code that takes a link to their health record. If you know what the smart health links are, this is something very close. It's not exactly, and I'll explain that in a few minutes. But they basically go through a health check and a consent to share their health records, and sort of steps 1 and steps 2, and an IPS is generated. So, okay, that's in their origin country. They do that a little bit before Hajj. Now they go on Hajj, and so in steps 3 and 4, they need care. And we're talking about conscious patients that need care. We're not talking about the break the class scenario. They go to the EMR, go to the registration, and they show their QR code to access the IPS, and that's downloaded to local EMR. So now the clinician in Saudi has as much information as they need to provide care. And then all of this is built on sort of the bottom, the Global Digital Health Certification Network, infrastructure provided by WHO to help the verification of the health documents, to make sure that there's no fraudulent servers around, nefarious servers that are serving up bad health information. You could say, oh, I have in a server, I could stand one up. I could say, oh yes, I've had all my COVID vaccines, and I'm on opioids, and I have lots of medication prescriptions. Like, we want to prevent that from happening, right? We need accurate health information. So the verification of these IPS documents is critical. You can see here some examples of how it was actually used in practice. So in the upper right, we have Malaysia. They had a national health portal, and it was integrated into the national health portal. So they can go in, I know this is hard to read, but they basically say, oh, go to Hajj Health Check, and they get their IPS through a QR code. Then on the Indonesian side, most of there was a bit of a different demographic. They don't have as much smartphone penetration. And so what they did is they have the Hajj pilgrims have a physical badge that they have with them. And then on the back of the badge was their IPS link. And I should say that these are time-bound, password-protected links, QR codes, and they're also digitally signed to do the verification. And over here you can see the Oman version. It's similar to the Malaysian version, and they have a national portal with the Hajj Health app on there. The number of countries that are lining up to do it for the next, not this Hajj, because it's happening now, it just started, but in the next year there's going to be a large expansion for a number of countries are just getting their IPS, sort of the national infrastructure in place so that they can do this. So how do we use the IPS? We basically just straight up IPS, except for we have the advanced directive sections that we actually use. So how many have used the advanced directive section for an IPS? One person, yay! What we did for the advanced directives is that we put in the consent for the pilgrims to share their health data. And we actually did it sort of two types of consent. One is that I'm consenting, if I was a Hajj pilgrim, I'm consenting to extract the records from my home country to share during Hajj. And then a second consent that says, when I'm in Saudi, I agree to share my health records to the Saudi authorities. So we sort of track sort of both sides of that consent. And when there's not necessarily clear bilateral policies that enable that system-to-system data transfer, this helps to mitigate some of the risks and the concerns there. You can see here on the left-hand side, sort of the consent statements from Malaysia and KSA that were used. And these are not the statements, but the codes for the consents are in the advanced directive section. So when that IPS is shared, you know the context that that IPS is being shared under. So you have that within the IPS. This is sort of thinking, forward thinking towards a time when we can get into computable data and sharing agreements, and what type of metadata do we need to have in place. So this is sort of thinking a little bit in the future towards that. But you can see on the right-hand side sort of some of the workflow. I won't go into this detail. Essentially that they select consent directives when they're doing their Hajj Health Check and when they're going through that, getting that QR code generation. And we make use of the IHE patient privacy consent framework for the transactions to actually record the consent. So that could be recorded, and then you generate the IPS further down. Okay, so that's the sort of Hajj health story. And I want to go a little bit more into what the GDHCN is and why that's important here. And really what we're thinking about is a personal health wallet, an individual holding their health data. And how do we know that as an individual carrying that health data, how do you know that it's authentic if you're a clinician or you're at the border checking what's going on? So we have, in your wallet, you might have the Hajj Health Card, which is like an IPS. There's the ICVP, or the yellow card, which is going to be digitized starting later this year. The process begins in September. You might have a maternal, child and health, and immunization cards. So these are typical type of paper records that people have, that we want to put on a digital wallet and do that in a secure way. So a lot of this work came out of the COVID work. And just to step back for a second, during the COVID days, there were lots of QR codes for COVID certificates. There's the EU system, the EU DCC, ICAO, the International Civil Aviation Organization, had a VDS-NC format. There's a India and sort of the regional format called DIVOC. In the US and a few other countries, there's the smart health cards, and there's a whole bunch of sort of country-specific ones as well. So none of these, I mean, they're all sort of almost the same data, not quite. They're sort of semi-interoperable, but nobody actually had done the interoperability. And they also all relied on the notion of a trust network, but they all used different trust networks. Trust networks to verify that that these were valid QR codes by issued by an appropriate authority. All of those relied on a public key infrastructure, but it was all different. So we knew that there was a gap. We needed a way to federate across all of these sort of trust networks. And that's where the motivation for the WHO's Global Digital Health Certification Network came in. So it sort of looked across all of these and built a national, global infrastructure for this. So how does that actually work? Sort of a three-step process. The first step is that a country, a member state, or eligible entity comes to WHO and says, hey, we want to join the network. WHO takes on sort of the most important part of that establishing a trust network is that we do that verification that this really is, Brazil, this really is Germany, this really is Netherlands coming and saying, here's our keys. And so that organizational identification is sort of the foundation of trust. So WHO, will do that organizational identification. It's through diplomatic processes. And then the keys are onboarded from a country in step one into the WHO's Global Digital Certification Network. So we're playing a role of a trust anchor. In the second step, we now distribute all the keys to the members of the trust network. We actually make these publicly available, but but we aggregate and share these out to any of the participants in the network. And at this point, WHO steps out of the equation. And now it's up to individuals that are traveling from one jurisdiction to another. They can take their health documents that have been digitally signed from, let's say, country A to country B. When they go to country B, they can say, okay, I see the digital signature. Let me figure out which key I need to verify it with. They have those keys from WHO already, and they do the verification. And so then they know, okay, this person that said they were from country A and they brought a health document from country A, it really is from country A. It's not a false document. And maybe some of the things that were important on this is who's in this network, right? So WHO member states and other sort of UN affiliates can join. And what we saw, just sort of thinking back to the COVID days, the EU was really hard for to engage with the US because the COVID certificates that were issued in the US were issued by the private sector. And there was no legal basis in the EU to actually trust those private sector networks. And so we needed to have some way of saying, okay, at a national or potentially subnational level to say, these are the, if you have a private network, fine, but here are the ones that are being recognized by the public sector. And so having that sort of public sector governmental sort of trust network established is really important. But just to maybe emphasize, in step 3, WHO does not see any data from the individual. It doesn't see any metadata. It doesn't even know that validation has occurred. Right? WHO has no sense of the traffic. We're operating the phone book. We're not operating the phone lines. We're not making the phone calls. We're out, okay? So this is privacy by design, and just to give you a sense of where we are as of May, we have around 80-some countries that are already joined or in process of joining. Green are fully in production. The blues are going through the onboarding. The region of the Americas this year, there's a Connectathon in October, Diego? Yeah? Okay, October, and the goal is to get another 15 or so of these countries turned green in that Connectathon. So they're gonna go through all the technical preparations and go through the formal onboarding process. So this is expanding. KSA, UAE are very close and in progress as well. So this is an expanding network, and it's a basis that we can do not just Hajj Health Cards, but all sorts of health documents. We have an IG, smartwho.int/trust, that documents sort of all the specifications and the onboarding process, which is admittedly a little bit tedious at the moment to get all of your key material in the right shape and the right algorithms and upload it in the right way. But that tediousness is paid off for a little bit with pays off in the end with the strong, transparent nature of the key submission and verification process. So, verifiable health links. This is sort of the technology that's underlying all of this work. It's an IHE profile that's in development, and so we sort of pre-adopted or sort of this during the Hajj. But it's a new IHE profile for basically going over what we talked about for WHO and for Hajj, but more formalizing it as an IHE profile so that it's not just WHO doing it. We want to get to the point where WHO is implementing another standard, right? It'd be a much better position for us to be in. So it talks about the publication, retrieval, governance of keys. We have bi-weekly meetings on Friday. If you're interested in the subject, please join. And it sort of covers the main use cases that we talked here. One of the reasons that we have verifiable health links instead of this smart health links are things such as some of the EHDS, European Health Data Space regulations, where there's an auditability requirement. You need to know who's accessing your health data. Okay? With the smart health links, that's not really possible. And so we just needed something that would be legal in the EU context. If you're thinking of Hajj, well, there are Hajj pilgrims that are coming from the EU to go on Hajj, so we needed something that was going to be working across jurisdictions. And if you're one of the main technical differences is that the QR code from a smart health link versus a verifiable health link, the verifiable health link is a signed QR code. So you know where it came from. So if you're an EMR, you can sort of ensure that you don't have a nefarious server behind you, providing bad data. We have a table in the IHE profile that sort of describes the differences between smart health links and verifiable health links on a number of different categories. I'm not going to read out this table, but you can find it online. It's in draft, so please fix it. Please engage with us to help make sure it meets your needs. But essentially, it covers sort of that exchange of key verifications, the keys for verification, and how you do verification of health documents. So we're very similar to the smart health links. It's just in the manifest, if you're familiar with smart health links, we're moving to more IHE, MHD style manifest rather than something that's more bespoke from the original SHL spec. But I have to say we're working very closely with the SHL spec team in the IHE profile to make sure that changes that we need from the SHL side to enable sort of the verification, the verifiable health link side are happening. And so I think it's a good example of HL7 and IHE working together. One of the things I talked about yesterday was the importance of testing infrastructure. We have all these Hajj countries coming in, and we need to have a good test infrastructure. We like the methodology of the IHE actor transaction for setting up the compliance testing, and hope to see more and more of that type of interaction between IHE and HL7 in the future. In any case, sort of technical differences is the verifiable health link is based on the EU HCERT. That was the specification for the EU's QR codes. So we have 75 countries or so that joined the EU QR code, the EU COVID certificate work. So we have around 75 countries that can already do this. All we did is that the COVID certificate was one claim, and we've now created a new claim for just essentially the VHL to put the link in there. So almost for free, we get a verifiable QR code, and a lot of infrastructure. It's already there. A lot of open source libraries to implement the spec are already there. You can find this HCERT spec on our Smart Trust IG. It goes into quite a bit of detail there, but essentially what we end up with is the QR code points you to a folder that has a number of health documents in it. So we have IPS as a JSON document, so you can consume it, into your EMR. We have it as a PDF, as I mentioned, because of the liability issues. They wanted something generated from the home country. We have a signature of the IPS as JSON, so we're using detached signatures. Canonicalization is a pain, and we wanted to avoid all of that pain. And we also included a signature for the IPS. We're not quite sure if we really needed that in the end of the day, but these are the types of the things that we put in the folder. And so, and that's now what the pilgrims carry with them. Here's an example of the payload that goes in. So essentially, you have a URL, which is what you can use to access the folder with those health documents. A key for verification. You've got an expiration time. There's a flag there's a PIN, and I don't think it was provided in this example, or it got cut off. But then there's a PIN to password protect it. So I just want to conclude with a few other uses of the Global Digital Health Certification Network and where we're seeing this expanded. The first is the international health regulations. So the international health regulations govern the yellow book, the yellow card for yellow fever and polio. Last May, amendments were passed to it to enable a digital version. So the original international health regulations said things like paper and signed by the hand of the clinician. Well, in a digital context, that doesn't exactly work out, and so there was no legal basis to make a digital form. So they've made some modifications to the language. So they've gotten rid of in the hand of the clinician, and they've said allow for, there's some other language in here for allowing for the digital versions. One thing I want to call out is they're saying instead of a signature, we can now have the relevant authority. So the way that we can interpret that, this is the jurisdiction that issued the ICVP or the yellow card. And so if we use the GDHCN and we know that it's digitally signed and we can check the digital signature, then we know that we have the relevant authority that issued it, right? So if it's within the trust network, we know it's a country, then we're good. The other thing is that these vaccines have to be approved by WHO. So WHO has a pre-qual database for vaccines. And so as we think through the digitization of the Yellow Book, we need to figure out how we make use of that. And so there's going to be a slight difference where before we were looking at vaccine codes, people had ATC codes or other types of vaccine codes, ICD codes. Well, instead of looking at vaccine codes, we're going to look at vaccine product IDs. So we're going to really pull forward the notion of a vaccine product catalog. We'll have the WHO pre-qual catalog, and if a country has their own vaccine catalog of what they're using in their country, that's fine, that's great. They can include that on their ICVP, as long as we have a mapping back to the pre-qual database, just so we know that we're compliant and that ICVP is compliant with the IHR, which is a binding international treaty. So you can see here a draft schema for the ICVP, which is, if you've seen the sort of the vaccine credentials, is very similar, except for now, so the product, the vaccine code, we now have a product ID. So that's sort of the key shift in approach now, because it just was a mess before. The different ways of doing COVID certificates before, they had different notions of what a vaccine code was, whether it's based on by the manufacturer, by the market authority, and it was too much metadata was needed, and trying to shove that into a small QR code that can be printed, it just wasn't feasible. So what the relationship to the ICVP, the IPS, the ideal space is that given an ICVP, we should be able to produce at least one entry in the vaccination section or a couple entries in the vaccination section of IPS. And if we have an IPS, we would ideally want to be able to produce an ICVP. So it should be some kind of, so you shouldn't have to have both an ICVP and IPS. If you have your IPS, that should be sufficient. We do have the questions around the vaccine product that we'll need to work through. That's not currently a notion of that in the IPS, but I think that's a solvable issue. A few other use cases. So the Pan American Highway for Digital Health is being established. This is generally the Central and South American countries. I think we have 17 or so countries that are participating this year or more. But it's really to enable continuity of care in the region of the Americas, people bringing their IPS or their vaccine records as they, fairly fluid and mobile populations across the country, so or across the region. And so the second step to joining the Pan-American Highway for Digital Health is to join the GDHCN. And so we will see sort of increase of use cases and uptake based on this. And there's an upcoming EU vaccine card, and that's work is just being kicked off, and it's early, but the intent is to make sure that the EU vaccine card also aligns with the Global Digital Health Certification Network. So if you have an EU vaccine card, then you can use it for the other purposes and make sure it's verifiable internationally. So I'll stop there so we have plenty of time for questions, and thank you for, 10 minutes. We've got plenty of time for questions, yeah.
Organization.
Yeah, so that's up to that's the policy of the host organization. So I don't know the details of Saudi's, for example, health law, but I think it's modeled after my understanding is, correct, it's modeled after the EU models. But WHO is not being an enforcer of this, right? We're creating the space that each country can determine, okay, yes, they're in the trust network, do I agree and to their policies or not? They make that decision for themselves. Joining the trust network doesn't bind you to trust all of the members of the trust network, if that was part of the question, yeah.
Did you look at, or was there any relevance of connecting with Saudi Nafi's health information exchange system?
Yeah.
As well as using the master patient index?
Yeah.
And all of that?
Yeah, so that is, so first of all of the work that we did for Hajj was so far been unfunded. It's all volunteer time. So yes, Nafiz was talked about, but I think it wasn't something that could be done under volunteer time. So, but my understanding is that is the plan. So the fees will start being able to pull in and request IPS from all EMRs is the plan, is my understanding, and that in the future, like when the pilgrims return back to their home country, they'll go to Nafiz. They've gone to maybe a couple different clinics. All those clinics will integrate their data to Nafiz, and then when the pilgrim returns home, they'll take the IPS from Nafiz. But that's not this year. That's next year, and I think that will be a fun resource next year.
I have a question about consent, because you have included the consent into the advanced directives of the IPS.
Yep.
So the pilgrim cannot repent. So if they say, I don't want to consent anymore, there's no way to stop the consent because it's inside of the document.
Yeah, I mean, definitely open to discussion about ways to do this better, but I think in this case that's okay because they're not allowed to go on Hajj unless they consent, right? So, so the consent, they can't take away the consent when they're on Hajj, so that's not an issue. I think longer term, that is an issue. But coming back to the IHE profile for PCF, I don't remember what's in there yet, but at the moment, but I think there should be a way to decline the consent and then have to regenerate the IPS.
If you don't store the consent in the document and you go to a consent store, then you can revoke it because you can say, okay, this is my consent for that document, and now this is my new consent for that document.
Yeah. But the issue is, what if you don't have access to the consent store when you're in the other country, right? So we got to be careful about that too. But yes, I mean, these are the things. Please come and join the technical experts group and the community practice on the Trust Wallet. Yeah.
So I want to ask Carl about a thing that you didn't really say, but I think falls out of the technical infrastructure, which at the moment is that your plan is that only countries will have access to put stuff in the digital health wallet.
No.
No, but that's the infrastructure, right?
There is infrastructure for stuff that goes into the wallet to be verified government to government, right? So, but we're not saying, I mean, we haven't made any requirements on what is in the wallet, right? So we're trying to, so this is why we need to have these communities of practice and these working groups to make sure those requirements come in. I think the notion of what a wallet is and what goes on there, we're still prototyping, right? We don't really know what all of that is. You know, we're going to do some work with Google on like, let's put the IPS on the VHL on the wallet just to, as it see what that showcase and looks like, but that's not saying the only things that go on the wallet. I think the one place where that is true is for the ICVP, right? The ICVP, because it's bound by this international health regulations, which is a treaty, which says this is a valid ICVP, has to be from a relevant authority, then an ICVP in the wallet, yes, has to be one that is authorized and issued by a government. But other health documents, you know, whatever is in your wallet, it's in your wallet. It's up to the clinician or the border security to figure out whether they want to verify that or not. We're not making any determination on that except for the case of the IHR because that's the law, right? That's the treaty.
Yeah, just going back to the comment of consent, I just wanted to confirm something, that if an individual no longer wishes to share their information, really the point of sharing actually begins with the individual, right? They've got to show the QR code.
Yep.
So if you don't want to give consent for someone to access that information, you don't show them your QR code, right?
Right. Yeah, so I mean, there is that physical
But
consent.
once you've shared it with them, they have a right to have that information.
Yes. So there is that physical consent that happens for the QR code. And because it's PIN thing, there's a PIN on it, we can stop drive-by, you know, photos of the QR codes that get accessed later or minimize that. I think the legal questions we have to ask is that physical showing enough for consent? I don't know that, like, for example, in the EU, physically showing is going to be enough. I've heard different interpretations of that. So that's why we also want sort of the explicit consent given before they go. How that happens outside of like the Hajj context where there's, you know, not the health check where they can go through the, you know, theoretically go through that consent and informed consent, I'm not sure. That's something that we're going to need to figure out.
I might have missed it in earlier discussions, but I hadn't realized that you were using the advanced directives section for that explicit consent of the about the document itself, and that's something I hadn't anticipated actually. But I wonder, does that sort of indicate that maybe we need to be thinking of another mechanism for, you know, with IPS for you to be able to do that?
And I agree that maybe we've been abusing the advanced directive section, but also there's not a lot of narrative text around what should be in the advanced directive section.
Right.
So
it's pretty open, but
yeah.
I mean, but we weren't really anticipating that.
Yeah, so maybe that's not the right intended use, and let's clarify that. I'm happy to. And if we do that, you know, I don't know how to. So, you know, the question is really, you know, coming back to, oh, well, we can't access the consent server anymore if you're traveling necessarily. Maybe we put the consent directives in here in the folder themselves outside of the IPS. You know, these are the things we need to talk through and work through what's the best way. At least we knew that putting it in the IPS, we knew that whatever happened to the IPS in the end of the day, even if it got divorced from the folder, we would be safe. So maybe both are needed. I don't know. Join the expert group, yell about it there, and we'll figure it out, okay?
Great talk, Carl. This is pretty exciting. My question is, in the context of the IVCP, you had mentioned moving to you know, vaccine product information as sort of the coded representation of that. So the question is I think you called it the pre-qual table or database of that, is there plans for sort of FHIR enabling that as a resource, or is that underway? As a repository or terminology server?
There's slides in another slide deck that has that. So we do have a draft IG that's gone through and represents those as FHIR resources. It's using, well, logical models first because another tirade around the representation of medical products in FHIR that I don't want to go into now. But yeah, so those are represented. There's a smart PCMT-Vax Prequal IG. So PCMT is a product catalog management tool, which we are deploying as part of our infrastructure. So we're going to put the vaccine prequal database on there, as well as some other stuff that we have that's product catalog like essential medicines, that type of thing. And yeah, it'll all be there. And the idea is, as long as you can map your national systems or regional systems to that, mapping exists, then that information is interoperable. Fingers crossed, right?
I get a little confused sometimes. So my question is, the work that Magnus is doing for Uppsala, for medication registration? That's one question, if it's related to this or it's another catalog. And the other one is, there's something called International Vaccine Code. This is also have something to do with your catalog, or it's a different catalog?
So I don't have any catalogs, just to...
No, who has no catalog? Yeah.
So I'm not responsible for anything, okay. No, so the WHO drug, there's a catalog there. That is not an open license catalog. Governments can get access to it. Because it's not open license, we can't easily make use of it for value sets and IGs. But that is only used for adverse event reporting. So ideally, if that opened up, we could have WHO drug linked to the vaccine, the prequal database, so that we know, okay, we've got, here's the vaccine record. Okay, we go to the prequal database to see what we need to get for the WHO drug vaccine reporting. But yeah, there's some, and then the other one, the IP International Vaccine Codes. There's this NUVAC stuff.
Yes.
Is that the NUVAC that was SNOMED?
Yes, NUVAC.
Yeah. So that is something that we've been talking with and coordinating. I think there's a lot of consolidation that needs to happen in the vaccine coding space, and it's not our role to consolidate that, but we do want to encourage that consolidation and make the linkages possible where they can be made.
We have still 5 minutes. No more questions?
I thought of one other simple one. Do you have a standard library that's doing the transform into the PDF rendering? Or how are you doing the visualization of the...
I mean, that's each national country.
Each national country.
Yeah, but I think they're using Happy or Smile in Indonesia, in Malaysia and Oman, but I could be wrong. But just as an aside plug, so the IPS rendering, that'd be great if those were translatable as well. So if anybody has, not just the IGs, but the IPS itself, right? So anybody has a FHIR server that renders IPS.
It's an official viewer, but I don't think it generates PDF automatically. That can be another functionality.
Yeah, right.
Yeah. Yeah. So hopefully one of them will magically be translatable in the near future, and we would be happy. And a lot of other people would be happy, yeah.
No more?
Jose, did you have a question? No.
Raham?
It's not possible at the moment for an intermediary to generate the PDF because we don't have enough control over the narrative or the content of the document. I'm adding some new tools so that we could, but then we would have to make those agreements in order to make an intermediary have that level of reliability, or else the WHO community could adopt those agreements or additional agreements that we couldn't get away with making. But right now, it's just, there's no safe way for an intermediary to translate the IPS document.
And just a brief comment on the Diego, when you said you are confused with the products and the initiatives. The moment that you get into those things, then you get confused. So that's already a good step, because there's WHO drug, there's ATC, there is IDMP, PHP IDs, and all those things. And at the end, and there's now NUVA, SNOMED is now onboarding NUVA for a catalog of vaccines, and there's CVX. There's lots of things there. What matters is that I carry my yellow book, and somehow the codes there, they have to be recognizable. If you ask regulators, they have very complicated systems. If you look at product catalogs in countries, they are all different. So that is part of the I think one of the good side impact of doing this, of forcing, like, it has to work, not in a jurisdiction, not in a specific catalog, but across borders. I think that's one of the good pushes here, is like, it's not working yet, or we need something else. And those initiatives, they'll have to see that there's different levels of granularity, there's different levels of different types of resources to represent all those things. We are just exploring the problem. I'm talking this from the FHIR and from the standard side. There's lots of things out there, and we have to make it work for this concrete use case.
Anything else?
No, please join the working group, and interested in all of your feedback, and thanks for the arguing today. That I hope to see that continue. So
thank you very much.